Okay. Hello and welcome to the ASCP CCO's Science of HER2-low breast cancer and implications for the pathology team video conference. My name is Dara Oken and I'm a learning experience designer at ASCP. I will be facilitating today's session. Copy of the disclosures can be seen on the screen. In addition, today's session is funded by independent educational grants from AstraZeneca and Daiichi Sankyo Incorporated. Please note that this video conference is being recorded and live streamed on ASCP's Facebook page, and by participating, you are agreeing that ASCP may use the recording of your image and statements on ASCP's Facebook page, website, and YouTube channels. So before we start, let's take a moment for introductions. Please type your name, title, and institution into the chat. Well, it's wonderful to see so many of you here. As you're introducing yourselves in the chat, let's introduce our presenters for today. Dr. Ayesha Sahin is Professor and Section Chief in the Department of Pathology, Division of Pathology, Lab Medicine at the University of Texas MD Anderson Cancer Center. Dr. Erin Downs-Kelly is Director of Breast Pathology at Cleveland Clinic, and Dr. Ali Brown is Chief Officer of Medical Quality at American Society of Clinical Pathology. So today is the first of two HER2-low breast cancer tumor boards, this one with a focus on the science and implications for the pathology team. Dr. Brown will first provide an overview of HER2-low breast cancer, followed by Dr. Downs-Kelly, who will discuss DESTINY in HER2-low trials. And finally, Dr. Sahin will share on evaluation and reporting. After the presentation, we'll encourage discussion, so please feel free to type in questions into the chat or Q&A functionality, and we will be able to address them post-presentations. Few final reminders. Please keep your microphone on mute until you raise your hand to speak during question times. In addition, please do not share any protected health information or personally identifiable information about patients. And last, CME CMLE credit is available for this event. Instructions for claiming credit will be shared at the end of the presentation, will be available on our breast cancer website, and will also be sent to the email address you provided at the time of registration. So now let's turn it over to our presenters to share their slides and begin.
Thanks, Dara. Sorry for the transition there. Well, thank you everyone for joining us. It's so exciting to see all the different names and locations that people are joining us from across the world, I see. And we hope that you get a lot out of the presentation today and have a good review of some things and learn a bunch of new things as well. I'm Dr. Ali Brown, and I'm here today with two of my favorite colleagues, and we're going to be talking to you about HER2-low breast cancer. The objectives today are to describe the science and emerging evidence around the diagnosis and treatment of HER2-low cancer, to review HER2-low clinical trials and the characteristics of what patients might be eligible for those trials, to discuss properties and characteristics of the types of treatment that are being used in these HER2-low clinical trials, and then to outline ways to improve communication and coordination between pathologists and in the multidisciplinary setting as well. So we're going to start with a polling question, just getting a general gauge for how familiar you guys are with the diagnosis and treatment of HER2-low breast cancer. Is this an entity that you've heard of? You see we have options here, so please go ahead and indicate them in the polling mechanism. Are you actually working in a center with HER2-low trials? Are you familiar with them, but you don't have a trial? Do you have kind of you've heard of it, but don't know much about it, or not familiar at all? And kind of not surprising, about half of you have heard of it, but are here to maybe learn more about it. Perhaps don't have trials at your organization so far. I know those trials are quite limited at this time, and Dr. Downs-Kelly will talk about that in a bit. So here we go. Excellent. Well, I'm glad not everyone just said they knew everything about it, because then I'd be like, what are we talking about today? But we are going to start with some basics. So just some HER2 basics that I would be remiss to proceed without talking about. We know that HER2 is a membrane tyrosine kinase protein that's encoded by the HER2 gene that's located on chromosome 17. And we know that the cytoplasmic portion of the HER2 receptor is constitutively active when overexpressed. And we also know that the HER2 gene is amplified in about 20% of breast cancers. If we think about the history of treatment for women and men with HER2 positive breast cancer, in the 80s, we had this initial publication that talked about HER2 gene amplification and it being associated with worse clinical outcomes. Around that time, a few years later, we started looking into that protein being a potential predictive marker for aggressive disease, but then also something that could perhaps be targeted for treatment. In the late 90s, a phase 2 trial showed that Herceptin monotherapy was effective in patients who had failed prior chemotherapy. And then in the late 90s, Herceptin was FDA approved for the treatment of HER2 positive breast cancer in the metastatic setting. So this is an entity that we've been familiar with for quite some time as pathologists. For those of us who are pathologists on the call, we know that HER2 is both a prognostic and a predictive marker. We know that prognostically, HER2 positivity indicates a perhaps more aggressive tumor with a higher risk of metastasis and a decreased survival when compared to non-HER2 amplified tumors. This is, of course, in the absence of therapy, and Herceptin and other HER2 targeted therapies have been tremendous assets to treating patients with HER2 positive disease. We also know that the marker is predictive in that it predicts the likelihood of a patient responding to these targeted therapies. So the ASCO CAP guideline recommendations starting in 2007 and with the most recent updates in 2018 were put in place to improve the accuracy of HER2 testing by developing an algorithm. A lot of us breast pathologists on the call, now everyone kind of has these tailored treatments for their cancer type. We've been dealing with this for a long time and have been going through proficiency testing and guideline recommendations. Breast has really been a leader out there in quality assurance of cancer markers. But these initial guideline recommendations talked about specimen handling, which assays to use, what are the reporting criteria, as well as definitions for positive, equivocal, and negative values. And they talked about immunohistochemistry, FISH, and then different types of bright field in situ hybridization. So since the HER2 protein is this transmembrane tyrosine kinase, we can utilize that to detect overexpression using immunohistochemistry. And then these results are evaluated as a degree and intensity of this membranous staining pattern. As I mentioned before, initially the trials were based on the FDA criteria for interpreting these immunohistochemical studies. And then ASCO CAP and CAP putting out this joint recommendation guideline in 2007, followed up by a couple more iterations in the most recent 2018 focused update. In the 2018 focused update, the IHC 0 and 1+ are still regarded as negative with these definitions that are here on the slide. I won't belabor it and read them, but there has been a slight change. So it's good to familiarize yourself with the updated recommendations from the 2018 update. Again, seeing a 0 negative case all the way on the left, followed by a 1+ also negative case, a 2+ equivocal, and then on the right, a nice 3+ dark circumferential membrane staining case. And we know that through these recommendations, tumors with equivocal immunohistochemistry results should have reflex testing, either on the same specimen using an alternative test or on a new specimen using the same test or an alternative test. There also is this category of indeterminate results, which is important. There are things that may arise that do not allow reporting of a HER2 result accurately. And it's better not to stick your neck out and try to make something of these, but instead to call them indeterminate. And they can be caused by a variety of reasons. And for cases like this, additional tissue should be used for testing. There are also these rare IHC staining patterns that were brought up in the 2018 focused update. These rare patterns are considered in the equivocal category and warrant additional testing. That is a moderate to intense IHC staining in greater than 10% of tumor cells, but that is incomplete. So it's this basolateral or lateral staining pattern, which I'm going to show a picture of, or circumferential membrane staining that's intense, but in less than 10% of tumor cells. So here's an example of a tumor that everyone has seen before, a micropapillary carcinoma. And this type of tumor characteristically can show this type of basolateral staining pattern in a majority of the tumor. So this would be a unconventional staining pattern and would warrant an equivocal result in additional testing. So prior to these HER2-low clinical trials, there was really no clinical applicability to reporting a negative HER2 IHC as either 0 or 1 plus. Technically, that is the outlined way to report a negative IHC. However, we've all seen reports in which people just call it negative and they don't kind of say which it is, 0 or 1 plus. This all changes with the advent of these HER2-low clinical trials and potential future HER2-low treatment that may become the standard of care in the future for patients. So we want to bring your attention to this as part of the talk. It really requires a differentiation between the two negative categories because a 0 HER2 immunohistochemistry would not allow a patient to be applicable for one of these trials. However, a 1 plus with negative FISH would be. And another thing would be, we don't usually perform FISH on our patients who have a 1 plus negative HER2 IHC, but for the purposes of this trial and perhaps future treatment, we would indeed. We know there's a lot of scoring variation. Dr. Sahin teases me that I'm going to say that everything is very cut and dry and easy to score these cases. We know that is not the case. It's a semi-quantitative assessment, right? So there's a lot of gray area. I'm not a computer, if I'm not using image analysis, and even there are issues with image analysis with determining specific cut points for percentages. What we have seen a lot in practice is that the threshold for 1 plus versus 2 plus can kind of be a bit cloudy with cases kind of being pushed more into the 2 plus category, which is understandable because a lot of folks kind of want to give the patient the benefit of the doubt that they'll have FISH to make sure they are or are not candidates for Herceptin therapy. So, there's quite a bit of variation still despite best intentions. And we will always have these borderline cases, and this can always cause some subjectivity. But we really want to address those measurements that impact our patients on HER2-low clinical trials today. So I'm going to go ahead and pass the baton to Dr. Downs-Kelly, who's going to cover this section about HER2-low clinical trials.
Thank you, Allie. I appreciate that. So we're going to talk about kind of some of the current HER2-low clinical trials. There aren't many of them, but there are a few. And we're going to frame this kind of in some of the background and how we got to where we are. So first, let's talk about what is a HER2-low breast carcinoma. Well, currently, we're kind of in the early days of this entity, and there's really no formal definition of a HER2-low breast carcinoma. We can say that of the trials that have looked at HER2-low breast carcinomas, they've included those cases that are 1 plus or 2 plus by immunohistochemistry, and they've had to lack amplification by an in situ hybridization assay. So if we use this as our definition of HER2-low, then really up to about 55% of breast carcinomas could actually be categorized as HER2-low. This is really a spectrum of heterogeneous tumors that have kind of varying expression of HER2 based on how we score them as either 1 plus or 2 plus. So if we look at these on a deeper level, the majority of these are hormone receptor positive tumors. And if we look at them by expression analysis, a lot of them fall into the luminal B subtype. Those that are, the remainder are basically hormone receptor negative, and on expression analysis, not surprisingly, they fall into the basal-like subtype. This was a large study that was done by Rossi et al., and they really looked at cases that we would consider HER2-low based on this definition. They were 2 plus by immunohistochemistry and FISH non-amplified, and it was really showing kind of the heterogeneity in these tumors. So in comparison to tumors that were HER2 truly negative, meaning 0 by immunohistochemistry, or even those that were 1+ by immunohistochemistry, these 2+ tumors tended to present at a larger size, be higher histologic grade, have a higher Ki-67 proliferative index, more frequently had axillary nodal disease, and really had a poorer prognosis. So how did we get here that we're beginning to think about HER2-low? Well, if we backtrack and kind of look at some of the original adjuvant trials looking at trastuzumab, some of those original trials had testing that was done centrally versus testing that was done locally. So in those trials, there were some patients called HER2 positive locally, but when tested centrally, they were called HER2 negative. And those patients were included in the trials, and it was thought that maybe some of these patients are getting some sort of benefit from trastuzumab. And the NSA-BP B47 trial really sought to look at this. So this looked at high-risk HER2 negative breast cancer patients, and then enrolled about 3,200 patients. They were stratified based on their nodal disease and their hormone receptor status, and whether they were immunohistochemical 1+ or 2+. And then they were assigned to either receive chemotherapy or chemotherapy plus trastuzumab. And if you look at the 5-year data, the invasive disease-free survival events, you can see there's really no difference in the 2 treatment arms in distance recurrence, regional recurrence, or death from disease. So this really told us that, at least in the setting of HER2 negative 1+, 2+ cases, trastuzumab was not beneficial in this patient group. So there are additional drugs to think about, and the ones that come into play as far as HER2-low trials go are really these antibody drug conjugates. And if we're talking about HER2, we're going to talk about HER2 targeting ADCs. And they are similar in that they have this monoclonal antibody, in this instance, trastuzumab, that's covalently bound to some sort of cytotoxic drug, which is typically called the payload or the warhead. And it's bound by a synthetic linker. So antigen binds on the cell surface, the ADC is internalized through endocytosis, and typically the linker is cleaved in the lysosome, and it releases the cytotoxic drug. And then the drug is able to exert its effects on the cell with which it's within, and when the cell dies, the drug is released into the extracellular space, and then it can affect bystander cells as well. So probably the most well-known ADC that has FDA approval is in the HER2 positive setting, and it's TDM1. It's trastuzumab emtansine. It's used in the metastatic setting for HER2 positive disease. It's also was the drug used in the Catherine trial. And these looked at patients who underwent neoadjuvant therapy with a taxane and trastuzumab-based treatment. And if they had residual disease after treatment, then they were either randomized into receiving additional trastuzumab or receiving TDM1. And the TDM1 group actually fared much better, and about a 50% less negative events, meaning recurrences. So it has been FDA approved. Remind you again, this is for HER2 positive disease, but that's kind of the beginning of our ADCs. Additional ADCs also used in the HER2 positive realm are trastuzumab deruxtecan. Again, this has monoclonal trastuzumab, cleavable linker, and this time the payload is a topoisomerase 1 inhibitor. So this is FDA approved for patients with unresectable or metastatic HER2 breast cancer, and it's approved in patients who have at least received 2 or more prior anti-HER2 based regimens. This is the kind of the data that supported that. This is the Destiny-1 trial. These are patients who were heavily pretreated. They'd had seen multiple lines of therapy, and this is in the metastatic setting. And you can see the waterfall plot on the left. This is the best percentage change from baseline in tumor size. And you can see that there was a significant number of patients who got some sort of reduction in tumor size. The response rate was about 60.9%. And the median progression-free survival for this group was 16.4 months. So at the same time that that was being looked at in HER2 positive disease, there were some studies that were showing that this trastuzumab deruxtecan ADC was having some effectiveness in HER2-low cell lines. So it was brought into a clinical trial. It was a phase 1b study. Again, this is patients with metastatic disease that is either HER2 IHC 1+ or 2+. These patients, again, were heavily had seen multiple lines of prior therapy. And when given this drug, they had a median duration of response that was 10.4 months. They had a median progression-free survival of 11.1 months and an overall survival of 29.4 months. The majority of these patients were ER positive, and I guess what I'd like to point out is that, you know, when patients go down this road and they're hormonal, you know, they're ER positive and they then begin to exhaust their hormonal therapies, they are then typically offered a single agent chemotherapy. And a lot of studies have shown that the median progression-free survival in that setting is roughly 3 to 5 months. So seeing a median progression-free survival of 11.1 months is pretty hopeful. So that really led to the Destiny-4 trial, which again is in the metastatic setting. These patients are IHC 1+ or 2+. They can either be ER positive or ER negative. They've had to have had 1 to 2 prior chemotherapies for metastatic disease. And their primary endpoint is progression-free survival. This study has reached its accrual goal and they're no longer recruiting, and we're waiting on outcome data from this. So the other ADC that's beginning to kind of see some phase 1 work and additional human trials is trastuzumab dual carmazine, and this time the payload is a DNA alkylating agent. This has shown efficiency in patient-derived xenografts that are HER2-low. And then it was used in a phase 1 trial that looked at kind of a broader spectrum of tumors that had HER2 IHC 1+ or 2+ expression, including some endometrial cancers, some GI cancers, as well as some HER2-low patients in there as well. And in those HER2-low patients, a percentage of them that were hormone receptor positive and a percentage of them that were hormone receptor negative did achieve a partial response. And the progression-free survival was 4.1 and 4.9 respectively for hormone receptor positive and hormone receptor negative patients. So let's talk briefly about a case review here. This is a patient that is in our institution, and we have the Destiny-4 trial open here. She was 40 years old when she was initially diagnosed. She presented with a left breast mass and enlarged axillary nodes in 2014. She had a biopsy of the breast mass, and it was called an invasive mammary carcinoma with mixed ductal and lobular features. That it was a Nottingham grade 2, and it was ER and PR positive. She was HER2 2+ at that time and non-amplified by FISH. In her initial staging, she was CT2N1A, and because of the nodal disease clinically, she had staging scans done, and she was found to have an ill-defined mass in the liver. The biopsy of that mass showed metastatic adenocarcinoma that was still ER/PR positive, and similarly HER2, 2+ by immunohistochemistry and still non-amplified by FISH. So she initially received docetaxel chemotherapy and then started letrozole and palbociclib after her oophorectomy, and she had a good response at that point. Her disease progressed in 2018, and she was started on capecitabine for about a year, and that was stopped when her disease again progressed So she was then started on fulvestrant, but not for very long, because then she had, again, progression in her liver. So at the time of that progression in 2019, she was again biopsied, still ER/PR positive, and because she was HER2 IHC 1+, and she kept having progression, she was excited to enroll and do the Destiny-4 trial. So she was fished at centrally and found to be non-amplified. This is that liver biopsy from 2019. You can see the little bit of normal liver there and our infiltrate of these epithelioid cells, just a higher power here to see this tumor. And if you go one more, then we can see her HER2 immunohistochemical stain, which really shows faint, weak membranous staining, but it is it's not circumferential, certainly, but it is in greater than 10% of the tumor cells. So this was called a 1+ HER2. So she enrolled in the trial. She is now status post 36 cycles, and she sustained a partial response since after cycle 3, and she has tolerated this therapy well. She's now 47 years old, and she still is going onward with a metastatic disease in her liver 7 years after her initial diagnosis. So, you know, that's a good story. There are always adverse events that we need to be mindful of with these medications and the cytotoxicities that can occur with them. And I would say some of them are very common that we see with other cytotoxic chemotherapies, like the hematologic and the hepatotoxicity in the GI. One to be aware of is interstitial lung disease that can be seen with the trastuzumab deruxtecan conjugate, and that's actually something that has to be monitored for when these patients are on this medication. So where do we go from here? There are obviously challenges in reproducibly identifying these HER2-low patients, and our definition so far is really based on our current HER2 testing methods and scoring system, and it's this largely semi-quantitative IHC. So in that earlier phase 1b study, where Modi showed that there was really tumor responses, and they were similar in both IHC 1+ and 2+ subgroups, it kind of brings up, is there an optimum test that we are going to have to predict clinical activity to these antibody drug conjugates? And is it going to be specific for the medication? Or do we really need to start to look at potentially more quantitative assays, which there are developing assays that can assess things more quantitatively than what we do currently. So far the studies have really looked at breast cancers that are 1+ or 2+ and FISH non-amplified. I think it raises the question, should cases that are IHC 0 be included in a trial to assess potential benefit in that cohort with some of these ADCs? And I think it brings up the point that if we're looking at something that's 0 or 1+, that things come into play that can affect our staining, whether it's the pre-analytics of cold ischemia time or fixation or length of fixation, or even the antibody and the antigen retrieval that we're using. I think these are all things that we're going to have to continue to be very mindful of going forward in this space of HER2-low. So with that, I'm going to pass it off to Dr. Sahin.
Thank you, Erin. As Drs. Brown and Kelly described very clearly, that in our clinical practice, we have standard criteria to evaluate HER2 status of breast cancer. Practicing in tertiary breast cancer center, I see many referral cases, and I am very happy to report that more than 90% of breast carcinoma cases today have good quality HER2 evaluation and standard reporting template. I think as general pathology community, we are doing a great job for evaluation of HER2 in breast cancer. We report IHC 0 and 1 as negative and 3+ as positive. And as Dr. Brown described, we do the reflex evaluations for 2+ cases. This dichotomous evaluation and reporting has worked, next slide please, very nicely in our standard practice to separate the HER2 positives and negatives, because the patients who have HER2 positive tumors, they are put on anti-HER2 therapy, and the patients who have negative HER2 tumors do not respond from anti-HER2 therapy. But as Dr. Downs-Kelly discussed very nicely, now there are different approaches to use HER2 pathway. Dr. Downs-Kelly described one approach, which is to use HER2 not as a target, not as a therapy target, but vehicle to deliver toxic drugs to the tumor cells, which have, even if it is low level, some HER2 expression. And in addition to this approach, there are additional approaches in pipeline to use HER2 pathway, including bispecific antibodies and vaccines. And maybe the methods that we evaluated to response to therapy using the monoclonal antibodies, separating as a dichotomous evaluation, HER2 positive and HER2 negative, is not adequate for these approaches. Next slide, please. Dr. Brown went over the slide and highlighted the distinction between IHC1, which is classified right now as negative, and IHC2+, which is equivocal. And when we have clear-cut cases, next slide, please, like this, when she showed, it is very easy. Unfortunately, in real life, we do not have a lot of clear-cut cases, and we have many cases. There is a significant overlap because we know that many biomarkers, including HER2, is a spectrum, and it is not either 1+ or 2+, but some of these cases, I call it like 1.5+ and 1.7. And then how are we going to classify these cases, especially if we are going to try to identify these low HER2 cases consistently? Next slide, please. And I would like to share some of these borderline cases with you today. And for some of them, I have a definitive answer, and others, definitely it is subjective evaluation, and we have to really, as a community, understand that there are these borderline cases. This is core biopsy of a 1.8 centimeter mass from a 52-year-old woman. As you can see, there's an invasive carcinoma, and we received the HER2 staining. Next slide, please. And as you can see, there is this low-level staining. I always evaluate any biomarker, including HER2, in low magnification first, because one of the issues is always the heterogeneity. And if there are some areas, staining is different than the others. I think in the chat question, when I was screening them, there is a question about heterogeneity, and then we will address that at the end of our lecture. In this case, the reporting was that, can I have the high magnification, please? That the staining, the weak membranous staining was in less than 10% of the cells, and it was reported as negative. But when we looked at it, some of the cells, we felt that it was really coming a little more moderate staining, and we said it is probably around a little about 10%, and we did FISH, and this case turned out to be a FISH positive case. Next slide, please. And this is another example, came to us with a diagnosis of invasive ductal carcinoma, 2+ immunohistochemistry and FISH negative. And when we looked at the staining, we felt that this is more like cytoplasmic staining, not 2+, and it is actually 0. Next slide, please. And when I look at these cases that we have disagreement, either from outside pathologists or among ourselves in MD Anderson, we have like 12 breast pathologists. And when we look at our cases, I think there are certain cases with specific themes that cause problems. One of these is these either luminal or intracytoplasmic secretions. Next slide, please. When you have these very low background type staining, please pay attention to these intraluminal staining. Next slide, please. The cells may have these little cytoplasmic and intracellular staining, but what we are looking for is membranous staining, not these granular looking cytoplasmic staining. Next slide, please. Another very important point in evaluation of any biomarker is that we always have to do histopathologic correlation. This is a corneal biopsy of 1.2 centimeter breast mass from 67 years old woman. And it is clearly low-grade tubular carcinoma type invasive cancer. And pay attention to all these adjacent breast parenchyma with columnar cell type changes and cystic changes with luminal secretions. Next slide, please. And look at these lateral staining pattern. It is around these well-differentiated glands. Next slide, please. And if you look at the other areas of this core biopsy, on the lower hand is invasive carcinoma, and the midsection is a normal breast parenchyma with lobular units. And next slide, please. Also, there is a very weak membranous-like staining in the first panel, which is normal lobular unit. So when you have normal staining like this, and to call these lateral staining around well-differentiated glands, you have to be extremely careful. Next slide, please. This is actually a patient who was considered to put one of the metastatic carcinoma low HER2 trials. She is 45 years old, had history of segmental mastectomy and axillary lymph node dissection for a high-grade ERPR negative, HER2 negative breast carcinoma, and she developed axillary mass 2 years after completion of her therapy. An ultrasound-guided core biopsy of the lymph node was performed, and here is the tumor associated with dense lymphoplasmacytic infiltrate. Next slide, please. And you can see that there is this low-grade faint staining. It's very difficult to appreciate if it is membranous or not. High magnification shows that there might be some accentuation around the membranes, but the majority of the staining is granular and cytoplasmic. So this should not be called 1+. Next one, please. This cytoplasmic luminal staining is not should not be confused with positivity. Next slide. So our final diagnosis on this one was metastatic carcinoma, HER2 negative, and she was not eligible for the low HER2 positive therapy trials. Next slide. Another important point that I would like to make is that when we are dealing with decalcified material, the staining quality may not be as ideal. This is a 69-year-old woman who was found to have lytic bone lesions on her follow-up, her breast carcinoma. She had ER-low positive, PR negative, and HER2 negative tumor initially. and she had a bone marrow biopsy, and her bone marrow biopsy showed metastatic carcinoma, and it was reported as HER2 2+, FISH negative, and she was referred again for this low HER2 trial. And this is her bone biopsy showing diffuse replacement by metastatic carcinoma. Next slide, please. And it was diffusely GATA3 positive, sporting metastatic breast cancer. And this is her HER2 staining, which was submitted for our review. As you can see, there is this background staining, even the erythrocytes in the background is showing this brown hue in the background of this blue cells, metastatic carcinoma cells. And when you look at the high magnification, you can really convince yourself, or is it really a little membranous staining? Should we give the benefit of that and then call this low positive, and so she will be eligible for the trial? In my opinion, when you have extensive background staining like this, we should be more rigid, and we should call this negative, not 1+ or 2+. Next slide, please. So again, on this one, our diagnosis was HER2 negative metastatic carcinoma. We have to be very familiar and be cognizant about repeating biomarkers in metastatic setting. Even if it is a less than 2 years between primary tumor and metastatic tumor, the discordance rate between primary and metastatic tumor is high enough that whenever we have metastatic tumor available, we should retest the tumor before we use the tumor biomarker. In this recent study, has not been published yet, but presented at the last ESMO meeting, show that 3% of initially HER2-0 patients can be HER2 positive, and up to 15% of those patients can be classified as HER2-low in their metastatic or in the relapsed setting. So 15% of HER2 negative primary breast carcinomas can be eligible for these trials that Dr. Downs-Kelly has mentioned. Usually the HER2 negative is going to HER2 positive, but even the other way around can happen. HER2 positive tumors can also lose their HER2 positive in their metastatic setting. So it's very important to retest HER2 status when we have metastatic tumors. Next slide, please. And in summary, in the past, we had this dichotomous evaluation of HER2 positive versus HER2 negative tumors. But now, actually, which we have these low HER2 breast carcinomas, and these tumors represent the majority of the breast carcinomas. Up to 55% of breast carcinomas can be classified as HER2-low breast carcinomas. So their accurate evaluation and their accurate reporting is going to be a major challenge for all of us. Next slide, please. And awareness of these cases is extremely important. We have these ASCO CAP guidelines predominantly for using HER2 as a target therapy, but as the additional therapy modalities become available, there might be changes on these guidelines. So following these things is extremely important. Making sure that when we report our negative cases, lumping them 0 and 1 together and report as negative as just a negative versus a positive may not be acceptable anymore. And for some of the trials, we may be asked to order FISH, even 1+ cases. And testing biomarkers in metastatic site is extremely important. And when our clinicians ask for this, we should not say that, oh, this is a patient with a known biomarker, so we are going to, not repeat it, is not an acceptable practice. So things can change in a metastatic setting. So we should really test these tumors. And consider a comment that some of the HER2 1+ and 2+ cases may be considered for HER2-low treatment options. Treatment decisions should not be based on oncotype HER2 results or any other genomic evaluation of HER2. All these clinical trials are based on immunohistochemistry and FISH, so we should not really replace one test with the other. For HER2 evaluation performed using other methodologies, resulting should be communicated back to the pathologist for correction. So this is the end of my presentation, and now we have a couple of polling questions, and I see several questions in the chat. I just saw Dr. Ellison from Stanford, so after the polling questions, we will come to the chat questions. Okay, the first question, this is an invasive ductal carcinoma, and we are asking you to classify this HER2.
Looks pretty good, like we have a consensus, Dr. Sahin. I think they consensus with us.
Perfect. Okay, second case. Another invasive carcinoma, high grade. There's a focal in situ. It's almost like a apocrinish looking tumor. And here is the HER2 immunohistochemistry. How would you report this case?
We see that the majority of folks feel like something else needs to be done. So equivocal or indeterminate.
Correct. In this case, definitely, Alec, can you go back to the slide? The staining quality is very different. There are some cases that I can see the membranous staining, but majority of the strong staining is this granular cytoplasmic staining. So it's a very difficult stain to evaluate. So either on this case, we would repeat the staining, and if it comes again like this, we definitely need to do additional evaluation by FISH or other gene amplification techniques to see if this is really positive or not. So it's either indeterminate or equivocal would be an acceptable reporting for this one.
We have some time for questions and comments.
Okay, thank you so much, Dr. Brown, Dr. Downs-Kelly, and Dr. Sahin. Yeah, let's open the floor for questions and comments. We have a very short time, and we'll be exploring methods to address all the pertinent questions that we do not get answered here today. Why don't we come back and address the question that Dr. Sahin mentioned about heterogeneity from Anthony Chi. Would you please comment on intratumoral heterogeneity in HER2 expression amplification in any given breast tumor? How are those scored? Will they benefit from new HER2 therapies?
Erin, would you like to mention that? Or?
Sure, sorry. So as far as heterogeneity, I think the thinking is that these are probably the patients that may actually respond to some of these therapies because of these antibody drug conjugate therapies, because there's kind of this payload effect and this bystander effect that can happen as well. So They're not specifically cited in any of the studies as of yet, but I would imagine that that's something that's probably would be potentially thought about in the future. As far as reporting heterogeneity, I'll say a little bit about reporting heterogeneity in FISH. It really needs to be a very discrete population, a clustered clone that is amplified, and it needs to compose at least 10% of the tumor. So in reporting those, they are still listed as positive, but it's said that they are heterogeneous, and you report both the non-amplified component and the amplified component separately. And just draw attention to the fact that it truly is a heterogeneous population.
There is an interesting question, and I think it really needs to be clarified. It is from one of the chat. It says, my practice, I routinely perform HER2 FISH on all breast cancers rather than HER2 IHC. Should be doing IHC upfront to identify HER2-low patients.
Well, for the purposes of these clinical trials, you have to know, specifically for that, the 0 versus the 1+, because just being negative on FISH would not make you eligible for the trial, if I'm speaking correctly, Erin.
I think so. And in addition to that, for the FISH equivocal cases, definitely we need to have immunohistochemistry. So the recommended algorithm to evaluate HER2 in all breast carcinoma is actually to start with immunohistochemistry and then do the FISH. And that is what we do in MD Anderson. Erin.
That's what we do too. I will tell you that years ago we did FISH as our upfront testing, but that was back in the days when we were in the 2007 guidelines.
Correct.
I think we're coming to the end of our presentation. I wish we could stay on Facebook Live and handle all these questions, but I will say that we have a second virtual tumor board coming up in just a couple of weeks, which is the continuation of this one. We'll ensure we have plenty of time at the end to address any questions we didn't in this talk, as well as new questions.
Thanks for saying that, Dr. Brown. And we do have time for one more verbal question. I see that Richard Cartoon, your hand is raised. Would you like to unmute yourself and ask your question?
Hi, can you hear me?
Yes, we can hear you.
Hi, Richard Carden. I'm actually a PhD biomedical scientist at Hartford Hospital responsible for immunohistochemical testing. Curious, which anti-HER2 antibody was used for detecting HER2 protein overexpression by IHC in this study? Or which one do you use at your facilities?
Which study in particular are you talking about?
These clinical trials looking at HER2
there are so many.
Yeah. So a lot of the Destiny trials and a lot of the HER2-low clinical trials, the testing was done locally. So it could be whatever the local hospital uses as their HER2 antibody. I will say that we use a Ventana. We use a 4B5 antibody at our institution.
Okay, thank you.
And the recommendation is not really to have a specific antibody, but to make sure that your quality controls and your antibody and your technique has been validated.
Okay, we actually need to shift into closing at this time, but I would like everyone to know we've taken note of all the pertinent questions you've asked, and as Dr. Brown mentioned, these will be addressed in the next tumor board, which will be coming up. Thank you again, presenters and everyone, for participating. There will be a short survey at the end. We'd really rely on your input to shape future education initiatives. This Thursday, we will have an upcoming actionable results and turnaround time indicators for NSCLC workflows video conference. But please especially tune in February 10th for the second in this two-part tumor board, HER2 testing in breast cancer, improving IHC performance, with the same expert faculty who is here today. If you'd like to claim CME CMLE credit for participating in today's session. You can visit the breast cancer page on ASCP's website or go directly to the ASCP store using the direct links in the chat. And ASCP will also send directions and the links for claiming credit to the email address under which you registered. Thank you again, and this concludes today's video conference.